Good evening. Welcome to our webinar. My name is Dr. Anaf Sab'an. I'm patient safety specialist at Saudi Patient Safety Center. I'm honored today to present our speaker, Dr. Asiri. Dr. Asiri obtained a bachelor degree in pharmacy in 2000 from King Saud University, and pharmacy doctor degree from North Dakota State University in 2006. He completed residency training in clinical pharmacy in 2007 from Wellesley Medical Center and fellowship training in safe medication management at Institute for Medication Practice ISMB in 2012. Our Dr. Mohammed today, he will talk about medication without harm. Please welcome with me Dr. Asiri. Dr. Asiri, mic is you.
Thank you so much, Dr. Anof, for this introductions. Good evening to all of you at KSA time and wherever you are. It's actually my pleasure to participate in this webinar talking about very important subjects in safe medication practice, which is medication without harm, focusing on polypharmacy and transition of care and medication reconciliations. Like Dr. Anof presentations, my name is Mohammed Asiri. I am currently the Assistant Director of Pharmacy Services at King Abdulaziz Medical City in Jeddah, and also an Associate Professor at the College of Medicine at King Saud bin Abdulaziz University of Health Science in Jeddah. Before I start my presentations, I would like to thank the Saudi Patient Safety Center and the WHO for the invitations to participate with you in this webinar. And I hope that you will find it very useful, that will help you in your practice setting. So in the next 60 minutes or so, I will focus my talk on 4 objectives. First, we would like to define the terminology of the polypharmacy and to understand the risk factors of the polypharmacy and the contributing factors that can lead to some of the medication errors and events related to the polypharmacy. And also we'll be talking about the medication reconciliations and the transition of care during hospitalizations, and also to recognize the health care practitioner role in this process. So these are the learning objectives. So before I start, this webinar, and I would like to know a little bit about the participants. I know that we have almost 300 participants until now, but I would like to know your professional background. So we have 5 physicians, A, pharmacists, B, nurses, interns, or other specialties. So if you can please start selecting the answer that match your professional background. And then 30 seconds. Okay. So we have physicians. We have a mix actually of physician, pharmacists, and nurses, and we have interns as well, and we have also other specialty. Great. Okay, so with the second questions, may I know your practice setting, whether you are practicing in academic center, acute care, ambulatory care, or other. So you have 30 seconds to answer this, and then we will see the results. Okay, so if you can allow more time, please, for people to answer the questions. Can you please put the question again, the poll question again? you can put the poll question again. Okay, so here you go. If you can please select. So we will give them like 30 seconds and then we'll see the results. Okay, so you can close the poll. Okay, so we have some participants with us in today's webinar from academic institutions. We have people from the acute care setting and ambulatory care and others. So we have a mix from different settings, which is a kind of, great because, the subject that we'll be talking about actually applies on different settings. So let's go to question number 3, please. So question number 3, what is your work experience? How long have you been practicing? Less than 2 years, from 2 to 5 years, 5 to 10 years, or more than 10 years? So you have 30 seconds to answer the questions. Okay, you can close the poll, please. Okay, if you can display the answers. All right, so excellent. We have actually the majority of attendees today they have experienced more than 10 years, and we have actually different level of experience. So great, thank you so much for sharing with me these answers. So let's start the presentations. The medication without harm. The medication use process is very complex, as you may know, and this involves different healthcare practitioners, include physician, nurses, pharmacists, respiratory therapists. So the issues of medication errors can happen in any stage, like in prescribing stage, dispensing stage, and administration stage. So the unsafe medication practices are a leading cause of injury and avoidable harm in healthcare system across the world. And it has been estimated that the associated costs with medication errors can reach up to $42 billion annually, at a global level. That's why both the healthcare practitioners and the patients have, a great role in playing, an important role to ensure safe medication practices. The WHO launched in 2017 a campaign in the third WHO, patient safety, addressing, the global patient safety challenge, which is the medication without harm. And the aim of this campaign is to increase the public awareness of safety issues related to medication use. And the strategies that was developed is for safe medication practices to reduce the risk of polypharmacy and the transition of care and errors that are associated with polypharmacy and at the transition of care, such as the medication reconciliations. So when we talk about polypharmacy, these days we have a significant growth in the older populations due to the advancements of healthcare and also medical technologies, preventive medicine, vaccinations, healthy lifestyle. So we start seeing people live longer than what used to be. So people reach now up to 70s and 80s, comparing to the years ago where the life expectancy was up to like 50 or 60 years old. With that, we see more and more prevalence of chronic diseases and multi-illnesses and comorbidities. And when people live longer and with these comorbidities, definitely is associated with more medications and multiple medication that needed to treat these chronic illnesses and comorbidity condition, which can lead to the polypharmacy. So when we talk about polypharmacy, there are many definitions in the literatures. One of the most common definitions that I saw is the administrations of a multiple medication at the same time, and or the administration of more than clinically indicated, and often represent as unnecessary use of medication use. So there is no universal number or universal definition with regard to the number of medication that the patient is taking by an individual patients to call it as a polypharmacy. But most of the new studies have defined polypharmacy as the concurrent use of 5 medications or more at the same time. And concurrent use is the key here because they have to be taken at the same time. So when we talk about polypharmacy, it has many consequences, but it's important that when we see polypharmacy and patients using multiple medication at the same time, that these medications should be used judiciously and should be used appropriately according to the indications. So judicious use of polypharmacy is valuable and fundamental for patient care. And this is what we call it an appropriate polypharmacy. And sometimes we end up having, more than 5 medications or 6 medications used by patients if it's clinically indicated according to the medical conditions that they have. And some of the study actually showed that more than 30% of the patients aged 65 years or older, they are taking 5 medication or more. And when we count on top of these, the OTC drugs, maybe more than 50% of the patients are meeting the definitions of the polypharmacy. So when polypharmacy is indicated, there is a medication that matched pre-indication, that this is what we call it an appropriate polypharmacy. But when we have an inappropriately polypharmacy or inappropriate use of medications, this will increase the risk of side effects, because these medications are not free from side effects. And these side effects can create a new indications to be treated, and we need to add another medications to the list that this patient is already have. If you increase the number of the medication that the patient is taking, definitely this will subject them to more drug-drug interactions. Patients usually adhere less with the increased number of medication, and if you have a lengthy list of medication, then this can cause decrease or reduce the patient adherence to the medications. Also, it will lead to increase the healthcare costs. Polypharmacy also can decrease the physical function. Some of the medications associated with falls and fractures, which can lead to a lot of complications down the road. Also, the inappropriate use of pharmacy or inappropriately polypharmacy can lead to cognitive function, memory problems, and also decrease the quality of life. So that's why we really need to focus on the polypharmacy, especially with the elderly populations. We need to assess their medications appropriately and making sure that the medication that they are taking is appropriate and matching the clinical indications, and also having the appropriate dose and frequency that will allow them to treat their medical conditions and not have these kind of negative consequences. The risk of polypharmacy can be related to the patients themselves or to the healthcare setting. Some of the risk factors is, as you know, with elderly, those patients at higher risk for polypharmacy due to their medical condition. Cognitive impairment, those who have a memory problem, they cannot remember what they are taking, they end up with the polypharmacy. And also lack of the primary care physician who would be able to compile the list of patient's medications and able to match the medications with each indications is so crucial. And many of our patients, they don't have primary care physicians, and they end up going to multiple specialties where each specialty prescribe their own medications, and then patients end up with a big list of medications. Also, those patients with multiple chronic conditions, multiple illnesses, they are at high risk for polypharmacy. There's also a problem related to the healthcare system. Poor medical recording or poor medical record keeping can lead to a polypharmacy where, some of the healthcare setting, they keep adding these medications without proper documentations. And then, with the next healthcare provider would not be able to know which medications the patient is currently on and for what indications. And also poor transition of care when patients move from setting to another setting, like moving from an outpatient setting to the inpatient setting, or to a long-term care facilities, or moving inside the hospital from one unit to another unit. This can lead to an increase of medication errors, which can lead to negative consequences. Also, many of those patients who are having chronic illnesses and comorbidities, they keep, asking the pharmacy to automatically refilling their medications, but some of these medications have been already, they don't need to refill them automatically, and they should have been stopped previously. So if you allow me just to mute for a minute, and I will be back with you on the webinar. Thank you. Okay, thank you. We will continue the presentation. So when you start any new medications with an elderly patient, just consider it as a trial, period, or a trial, to consider a trial period rather than it's a permanent addition of medications. Because if somebody, came with a complaint of like they have a difficulty falling asleep, or a joint pain or something like that, we would like to start with them like in a trial period. First, we would like to use the non-pharmacological options first, and then if this is failed, then we can start a trial, a small dose of medication, and then we need to do a follow-up in a timely manner, like after a few weeks or something like that. Just make sure that this medication is working as the way it should be, and the patient is in compliance with the drug. And if the medication did not work, we need to stop it, and then we can start other options. And also, as I mentioned, we have to assess the effectiveness and the safety in the follow-up visit. We need also to stop renewing refill medications. And when we refill these medications, we need to consider the benefits of them in terms of the clinical benefits versus the risk of continuations, like the side effects and the other issues with these medications. This slide is showing that the sequence in how to manage a patient with the new medications, for example. So when those patients are coming to you, you need to interview them, you need to interview the patients, the caregiver, to look at the medical conditions, review the patient records, and gather full information about the medication list that they already on, because maybe one of the medical conditions that they start having is due to a medication that they already on, and we don't want to treat the side effect. That's why we need to have a full understanding about the medication list before we start treating those patients. So we need to assess all medications for indications of use. If the patient has a list of medications, then during this visit, to assess the medications and make sure that every drug has the clinical indications. Also, you need to interview the patients, making sure that they are benefiting from these medications. If they have a GI pain, for example, they don't have this pain anymore, and then you need to look at whether we need to stop the drug or not. And also, we need to assess if there's any kind of drug-drug interactions or any issues with the medication that they are on. Also, we need to make sure that when you prescribe a new medications for the patient, that the patients, especially the elderly patients, because they have some of them have difficulty accessing the healthcare, some of them they don't have health insurance, some of them they have difficulty in affording the medications. So making sure that the patients, the treatment cost can be afforded by the patient is so important. Also, when we assess, when we put the plan for those patients, once we write the prescription, we need to make sure that is there any drug that can be discontinued at this time. Are these medications have to be continued with the same dose, or we can reduce the dose, or we can consider something called the de-prescribing process. So the de-prescribing process is looking at the patient regimen and trying to either to reduce the dose or stop some of the medication that they are currently on with no clinical indication. So elderly patient population are very vulnerable, and it's really important to assess their medications at each time of the visit. So as I mentioned, there are some tips to avoid polypharmacy: maintain accurate medication records, including the vitamin, OTC, and the herbal medications, review the medication regularly, and each time a new medication is started. And it's important to determine therapeutic endpoint and plan when you assess those patients, and avoid any prescribing to treat any side effects of another medication. So you need to look at the medication that caused this side effect and stop it. Again, think about risk versus benefit, and consider medication costs, especially with elderly. I would like to put these questions as a poll question before we move to the next subject. As you know, that there is no universal definition of polypharmacy with regards to the number of medication that are taken by an individual patient. However, most of the study have defined polypharmacy as there's a certain number of medication that can be taken at the same time or more. So is it 3, 5, 6, or 7? Start answering, and you have 15 seconds. Okay, you can close the poll, please. Excellent. So again, there is no standard definition, but most of the studies actually mention that the number of concomitant medications is 5 or more. So, and this was answered by 65% of participants. Question number, so we'll go to another poll questions. So which of the following consider negative consequences for inappropriate use of polypharmacy? Side effects, drug-drug interactions, non-adherence from the patients, and also all of the above, which is D. Start answering, please. Okay, close the poll. Excellent. So 85% answer all of the above, and this is correct. So we can see side effect with more medications, drug-drug interaction, and the patients adhere actually less to the medications when they have polypharmacy or many medications taken together. All right, so moving now to the medication reconciliations and the transition of care. So I will start with this case scenarios that happened actually in my hospital. We had a 60-year-old female with past medical history of hypertension, dyslipidemia, diabetes mellitus, heart failure, and hypothyroidism, who was admitted to the hospital through the emergency room. She was in a big list of home medications, which considered to be a polypharmacy, treating multiple indications, including levothyroxine 25 microgram daily for the hypothyroidism. During the admission, patients provided not a clear handwriting list or handwritten list of her home medications, which include levothyroxine 25 microgram. Due to a busy admission day in the ER, as usual in any healthcare setting, the team resident used the list from the patients for the admission order, and the residents noted the levothyroxine units, which is U, and misread it as a 250 microgram daily instead of 25 milligram. Patient received this dose during the hospitalizations for the next 12 days, and she developed fever, hypotensions, giving a concern of mixed septic shock and cardiogenic shock. The thyroid stimulation hormone was low, and the free thyroxine or T4 was significantly high. The endocrinology was consulted in this case and felt that the decompensation consists with thyrotoxosis. On detailed review with the patients, she reported that she was taking a levothyroxine 25 microgram before the hospital admission instead of 250. And then after that, the levothyroxine was discontinued. So if I may ask you, what do you think? What actually led to this clinical scenario with this complications during the hospital stay? If you can use the chat box, please. And we will see some of your answer in the chat box. what do you think, the main reason behind having this clinical? Okay, so handwritten list, I agree. Okay. So the dose of medications, also I agree the dose is incorrect, inaccurate. What else? Okay, so the doctor should take very carefully, correct. Overwork, I agree also. Absolutely, communications is a key here. There was a miscommunications from the team with regard to patients' medications. Okay, educations for patients, history of medications, okay. Miscommunications, patients' reconciliations. All of your answers actually is correct. Thank you so much for providing these answers. All right, so as you can see here, there was a miscommunications from the medical doctor, that the problem of using inappropriate or prohibited abbreviation like Q, it was misread as a 0 on a state of 200 or 25, it was written as 250. Also, as you may know, that there was no comprehensive medication review by, asking the patients, asking the, family members, or taking another source of medication for the medication use, rather than this list with not clear handwriting. So we are setting the stage to talk about transition of care and what could happen during the transition of care. So transition of care is the movement of patients from facility to facility, from unit to another unit, and or from the hospital to from the home to the hospital, or from the hospital to inside the hospital, from unit to another unit, or from the hospital to the home health care, or to the home. And this kind of transition will increase the possibility of communication errors, like what happened with this patient, and can lead to serious medication errors. So that's why the WHO and many organizations has put a lot of emphasis, like Joint Commission, Sibahi, put a lot of emphasis on improving the transition of care, and due to the medication errors and the medical errors that can happen during this crucial phase. So medication reconciliations, or what we call MedRec, it's a formal process that will compare, the accurate and comprehensive medication history from the patients and other sources, not only with the patients. Usually this process called best possible medication history, and we will be talking about best possible medication history, versus the medication that was prescribed at the time of admission, transfer, or discharge. And discrepancy are identified and brought to the attention of the health team. In another word, the Joint Commission has defined the medication reconciliations by the process. It's the process of comparing the medication patient is taking or should be taking with the new order from the physician, in order to resolve any discrepancy or any potential problem that can happen, like like what we show in the clinical scenarios. So implementation of medication reconciliation process will reduce the number of unintended medication discrepancy that can happen, like what happened in the case scenario. It can definitely reduce the potential of medication errors and will improve the patient safety. The goal of the medication reconciliation is to provide an updated, most accurate and complete list of medications of the patients, and using this list at all transition of care, at the time of admission, and when patients move from floor to another floor, or at the time of discharge. And this list is very comprehensive, including the medication name, the dose, formulation, route, frequency, indications, and also adherence. So why medication reconciliation is important is because of the errors that happen during the transition of care, like in the clinical scenario that I just presented. So it's really it's important because it will identify and resolve any medication discrepancy that can cause medication errors. There have been a lot of studies showing that around 50% of the medication error occur during the transition of care, and 30% of these errors are actually harmful error, which can lead to increase, prolonged hospitalizations and clinical interventions. Improve communications between and among clinicians, patients, and informal caregiver is really important. And also it will ensure an accurate and current and comprehensive medication information that can also the patient can use it even at the time of discharge. In our center, we conducted a study back in 2014, was published in 2017, showing that the number of, or the percentage of unintended medication discrepancy occur in about 50% of the patient at the time of admissions. And most of these errors actually were omission error. Patient was supposed to be on the medications, and this medications was not included, at the time of the admissions. We can see also omission, we can see inaccurate dose or inaccurate frequency as well. Who is responsible for medication reconciliations? The responsibility of the medication reconciliation does not rely on one specialty or on a facility or patients, but actually everybody is responsible and everybody is involved. So performing medication reconciliation involves multidisciplinaries working together in a team for the sake of that patient, and making sure that the patient has an accurate list of medication that can be used during the transition of care. So patients has a responsibility to give an accurate, up-to-date list of the medication that he is currently taking with the help of his caregiver. As well, a physician should be taking an accurate medication list. Hospital pharmacy should also supply the list of medication that the patient is currently on with the community pharmacy. And, everybody is involved in this process. It's also a requirement of some of the accreditation bodies. So in Saudi Arabia, we have SIBAHI, or the Saudi Central Board for Accreditation of Healthcare Institutions. It's the local accreditation body of healthcare institutions. The accreditation process is a mandatory process, and SIBAHI has standards related to medication use. If you look at the standard number 20, they are asking that the hospital should have a safe prescribing, ordering, and transcribing a process of the medication order, and it should be guided by a clear policy. Also, under 20.3, SIBAHI is addressing that the medication reconciliation should be conducted at the time of admission and at the time of discharge as well. Joint Commission also is requiring that the medication reconciliation should be done at the time of the admission. So they are asking that the patient record contain a list of the current medication taken prior to the admission, and this information also should be made available to the pharmacy and the patient care provider. And there should be a process to initiate medication and to compare this medication list that the patient is taking in the hospital with actually the medication order that the physician puts in the system or for the patient. Also, the requirement at the time of the discharge, a Joint Commission is asking that the discharge summary should contain the significant medication, including the medication discharge, and patient education should be done at the time of discharge to counsel patients about the new medications that have been prescribed, and what other medication that stopped or changed at the time of the hospitalizations. So how medication reconciliation can be done, how we can do it in the hospital setting. So we have two approach or two models. we have a model called proactive model, proactive medication reconciliation model at the time of admission, where a pharmacist or a physician or a nurse come at the, at the time of the admission immediately and create the best possible medication history. Interviewing the patients using two sources for the medication history. And this best possible medication history will be made available to the admitting physician to be utilized and to write the medication order that the patient will start in the hospital. And then we'll go to the pharmacist to verify the prescriber medication order, and also to compare it with the best possible medication history that was conducted prior to writing the medication order, and resolve any discrepancy if there is any discrepancy. This proactive model, requesting that you should have like a medication reconciliations team who can do the process of medication reconciliation as soon as the patient gets admitted to the hospital, because most of the hospital policies requiring patient assessment and within 4 to 6 hours of admissions. This assessment will include the medication, the medication that this patient should be taking at the time of the admission. But the most common approach that hospital using is the retroactive medication reconciliation process, where the primary medication history will be taken by the admission team, and patient will be admitted, and then the pharmacist will process the medication order, and then within 24 hours someone will come to take the best possible medication history using a systemic process and interviewing the patients, and the pharmacy or that person will compare the list of the best possible medication history that was taken from the physicians using two sources with the medication order that was written by the primary physicians, and also resolve any discrepancy if there is any discrepancy. So both model can be used at the time of the admission, but the first one would require a prompt medication reconciliation process, which can be difficult in some institution who cannot perform the medication reconciliations upon admission, like within the first 4 hours, I see. So when medication reconciliation should be done, it should be done within the first 24 hours of hospital admissions. It can be done also at the time of transition of care in the hospital, when patients move from a unit to another, so from low risk unit to a high risk unit, like from medical floor to an ICU, or from ICU to a medical floor, and also at the time of discharge. So it can be done at the time of the admission to the hospital, it can be done at the time of the transitions between units, and also at the time of discharge. Interviewing the patient is the key in the medication reconciliation. So it's really important to have somebody who is an excellent communicator to talk to the patients and to take the best possible medication history from the patients, because this can be a quite challenge sometimes and time consuming. That's why the ISMB Canada, they created a beautiful tool called Best Possible Medication History. I would recommend you to go and read the medication guidance, or the guidance in how to conduct medication reconciliation by using the best possible medication history. It's a systemic process to interview the patients, and this process should rely on at least 2 reliable sources of the information to obtain and verify the patient medication. We cannot rely on one source. We cannot rely on what the patient said to me, or the previous medical record that this patient on this medication. So we need to use a multiple resource or multiple sources in order to confirm the accurate patient list. So if you compare, the process of the primary medication history that is taken by, a medical doctor or by the physician at the time of the admission, and with the best possible medication history that we are looking for, usually the primary medication history is created very quickly to capture a list of medication at the time of the triage. And, the prescriber or the physician usually is busy with the admissions, and in ER it's a quite challenging environment. But when patients get admitted, and someone will come with a systemic process, to look at the medication history that this patient is taking, it's going to be more accurate. The primary medication history also created without using two sources, or at least more than one reliable source. That's why sometimes it has its own deficiency. But the best possible medication history using different sources. We use the patient information. We interview the patients. We go to the electronic medication dispensing record. We can ask the patient to bring the medication vials, refer to other healthcare facility and asking them about the medication, administration records. We can contact the community pharmacy to see what this patient is currently on. So we are using different sources. And also the primary medication history are missing necessary or essential element for medication information comparing to the best possible medication history. So who can do the interview for medication reconciliation to obtain the medication history and to do the best possible medication history? In the literature, it has been done by varieties or by different healthcare practitioners and physician, pharmacists, nurses, pharmacy technician, pharmacy interns. Also, in my institution, actually, we are using pharmacy residents who are doing a training program with us to conduct the medication reconciliation. But the key is you need to focus on somebody who is an excellent communicator, who can talk to the patient and extract all the information needed to obtain the best possible medication history. But in reality and in practice, this process has been done by different specialties, including physician, pharmacists, nurses, and pharmacy technicians. However, pharmacists, they are in a unique positions to use them to conduct medication reconciliations, because they have the knowledge, the skill, the position, and that will allow them to interview the patients. They have the backgrounds in pharmacology. They studied 6 years in pharmacy school. So they are in excellent positions to to support the medication reconciliations process and to be utilized in taking the medication history from the patients. And according to some studies comparing pharmacists versus other professions conducting medication reconciliations, they found that pharmacists document significantly more admission medication changes compared with the physicians. And also pharmacists routinely compile more accurate medication history than physicians and nurses. So we understand that sometimes we have pharmacy shortage, lack in manpower, and difficult to allocate pharmacists to do a medication reconciliations. So if it's difficult, then we can focus on the high-risk patient populations, which we see a lot of adverse drug events during the transition of care with them. So these patients are usually those with polypharmacy, those with who are elderly patient populations, and with multiple comorbidities. So when we look at the formal process for medication reconciliations, it does involve 4 steps. The first step is obtaining and collect informations to compile a list of patients' current medications, including dose, route, frequency. It's important to verify and confirm the accuracy of this information by using 2 reliable resources or sources. And then we can conduct the reconciliations, comparing the best possible medication history with the medication that was prescribed by the physicians at the time of the admission. And we need to identify and resolve any discrepancy. Once we identify the discrepancy, then we can communicate it with the medical team in order to take their opinion, whether to continue with their plan or change the plan. And it's important also to document this interventions, because you can identify discrepancies, you call the team about them, but then there is no actions. So it's really important to document these interventions, whether they are intentional or unintentional. So, the first process is by obtaining, like what I mentioned, by obtaining and collecting all the patients, all the information related to the medication use from the patients. So you compile the list. There is an excellent interview guidance by the ICMP Canada with regard to the best possible medication history, that they guide the process on how to ask patients about their medications and how you can conduct the interview. There are some tips that you need to keep in mind when you take the best possible medication history. It's really important first to review the patient's file before you go to the patients and meet them to talk about their medications, because you need to see their past medical history, their comorbidity conditions, and other medications that they are using. It's important also to talk about the non-prescriptions medications and herbal and vitamins, because some of patients, they consider these as are not medications, but it's really important to be involved in the medication reconciliations process. Do not assume that the patient are taking the medication according to the prescription vials, because they might show you the boxes, the pill boxes, and these kind of things. And don't take the information from the label itself, because the patient might take this medication in a different way. So it's really important to confirm it with the patients. It's important to use open-ended questions. Ask them tell me about how to use these medications, so they can talk to you more about this, about how they use it. Use medical condition as a trigger. Also, if patients, for example, you can ask him, what do you use for your hypertension? Okay, I see that you have a diabetes, so what do you use for your diabetes? Because sometimes you look at the blood glucose level or H1AC and you find it is very elevated, but actually they are not taking any medication because they stopped the medication, the medication that treat their diabetes, because they feel that they are getting better. Consider patient adherence with the prescribed regimen. You can ask them when was the last time you recently filled the prescriptions, and they can tell you about it, and then you can document it. It's really important to verify the accuracy, not only to rely on what the patient said, but it's important to verify it with other sources like what we mentioned. You can communicate with the pharmacy, of course, whether it's a hospital pharmacy or outpatient pharmacy, to confirm this information. So as you can see, the process is quite lengthy, and in the medical literature, this process can take from 10 minutes up to 45 minutes. And in a study that we conducted, it actually took an average 20 to 25 minutes to obtain a best possible medication history. So once you take this, again, you verify the information using two reliable sources. And sources, again, can be from the patient medication list, can be from the patient medication or medications. You can talk to the caregiver, you can talk to the community pharmacy. So you can use reliable sources to confirm the information. Once you confirm the information, then the reconciliation process starts. This is a screenshot, is taken from our hospital information system. In the left, you can see the best possible medication history. In the right is the admission order, and you give the physician now the option to decide which medication has to be continued, which medication has to be discontinued, or change or withhold. So this process can be done electronically, can be done manually. It's best to be done electronically, so you can keep it in one place, but it can be done also, as I mentioned, manually. Again, the best possible medication history can be done at the time of the admission. So you compare the best possible medication history with the admission order. It can be done at the time of transfer. So again, you use the best possible medication history that was created at the time of the admission, and you compare it with the medication administration record for that patient during the hospitalization, and you compare it to a new transfer order to the other unit that this patient is going to go to. And also at the time of discharge, you can use the best possible medication history that was taken at the time of the admission and compare it with the MAR, which is the medication administration record at the time of the hospitalization. And also you look at the discharge order, looking at which medication has to be continued from the hospital, and what other medication that has been held during the admission, and whether we need to go back and resume them again. Once you complete the medication reconciliations, it's really important to do the communications with the medical team and do the documentations in the healthcare records. These discrepancies that we see in the medication reconciliations can be intentional by the physicians. So the physician is intended to do this discrepancy. So for example, patient was admitted with hypotension, so the physician decided to stop the medication that treats the blood pressures. But the physician did document this very clearly. So this is going to be easy for the one who will be conducting the medication reconciliations. Some of the medication reconciliations, some of the discrepancies are undocumented, but they are intentional. So the prescriber made this intentionally, but there was no documentation why he stopped the medications or did this kind of discrepancy. But the most important thing is the unintentional discrepancy, the one that the physician did not mean to have. So the prescribed unintentionally changed, added, or omitted a medication that the patient was taking prior to the hospital admission. And this could be an omission where the patient or the physician forget to add the medication to the patient medication admission order, or commission by adding a drug that the patient is not currently on. All right, so using the poll questions, let's ask this question. So the medication reconciliation process can be performed in which of the following stage during the hospitalizations? A, during the admissions, B, during moving from a low-risk unit to a high-risk unit, C, at the time of discharge, D, all of the above. So you have 15 seconds to answer. Okay, close the poll, please. Excellent. So the majority mentioned it's 84. Of course, it can be done at the time of admission and discharge, but the correct answer is all of the above. Okay, so like any process, there is no process in the hospital without challenge. Okay, these are some of the challenges in the medication reconciliations, and I believe many of the institutions, including your institution, is having. Often there is no clear honor for this process. Who should do the medication reconciliation? Who should do the best possible medication history? Is physician, pharmacist, nurses? There is no clear honor for this process. There is a time constraint. It's a time consuming. As I mentioned, doing it the way it should be done and appropriately, the time can range from 10 minutes to up to 45 minutes, on average 30 minutes. So if you have, for example, 30 or 40 patient admission on a daily basis, who will be eligible for medication reconciliation, then this will take time, and you should devote a special workforce or manpower for such services. Also, the difficulty to identify accurate source of informations. This will take multiple sources again, and probably that's why you need to use more than one sources of medication to obtain this information to come up with the best possible medication history. Poor health literacy from our patients. Sometimes, patients, they don't understand or they cannot communicate about, the medication that they are currently on, or how they use these medications and what they are for. Patients do not know or cannot tell us what they are taking, and I have seen this a lot, and that's why sometimes, especially with the elderly patient population, we go to the caregiver, we go to the back to their primary physicians, and we try to access multiple sources in order to come up with the accurate list. Patient does not want to admit what they have been taking because sometimes they seek healthcare and from different institutions, and they want to hide this from their other physicians or doctors. Label of the that is put in the bottle sometimes are not clear. Patient may take medication differently than it's prescribed, so do not assume that what's written in the prescription from the different center is accurate. That's why we need to interview the patients or the caregiver. And sometimes the medication lists are often inaccurate or not correct. Patient education is a key, with the medication reconciliations. So once we reconcile the medications at the time of discharge, it's really important to talk to the patients and educate the patients about their up-to-date list of medications, and make sure that they understand each medication and what they are taking it for, and supply them with hard copy and written materials that will help them in order to understand how they use their medications. Also, it's important to give them a telephone number where they can reach to this number if they have any kind of query or questions about the medication that they are using. Also, supply them with an accurate list of medication printed that can be used when they go to their primary care physician or their hospital pharmacy or their community pharmacy, or in case they have admissions to a hospital where they can use it. I would like to acknowledge some staff or people who helped me in putting this slide together. Dr. Khulud Abdelghani, she is the medication reconciliation champion in our institution and a clinical pharmacist. My resident who is doing a medication reconciliation rotation with me this month, Dr. Sabreen Bakhsh, and also Dr. Abir Hanna from the Saudi Patient Safety Center, and Dr. Maryland Abdel Jawad for their help and support. With that, I would like to thank you for your attention. These are the references that were used to put these slides. And thank you so much for your attention, and I would like to entertain any questions that you may have.
Thank you, Dr. Mohammed, for your great presentation. And now we can invite our participant if they have any question. Please put your question QA icon. Actually, Doctor, there is a question from Dr. Abdul Wahab. He asked, some patients refuse to change or stop any medication that they use it as you see as doctor. What is the best way to do with them as your opinion?
So I'm going to read the question again, that some patients refuse to change or stop any medications that they use as you see as a doctor. What is the best way to do with? That's why in the previous slide, I mentioned the patient education. Patient education is key and crucial. They need, those patients need somebody who can talk to them about their medications, about their, clinical conditions, how this medication can help them. Because sometimes, the medication can cause side effects to them. And they don't want to continue the drug if there is a side effects. So if somebody gives them an assurance that these side effects can resolve, can go away after like a few days, because this is expected when you are using these medications, or you give them a follow-up to see if this side effects still persist, and we can change it to another medication. So patients usually like somebody who can talk to them and give them attention and time to discuss and talk about their medications. So this is like what I would suggest, from our practice setting. That's why, as I mentioned, we supply those patients in the medication bag. We put, a telephone number where they can access it, where they can call and have any inquiry about their medications. Some centers actually, with high risk patient populations, they call them themselves to make a follow-up about their medications and if they have been taking it as the way it should, and what are some of the challenges that they have. So they do a follow-up call after discharge. Could be like a few days after discharge, they give them a call just to make sure that they are taking the medication as the way it should be, and there is no problem. So these are some of the strategies that can be conducted.
Great. Doctor, there is another question. If I am a pharmacist in community pharmacy and we want to initiate the medication reconciliation, what's your advice to do, or if you have any strategy we can follow it?
Yeah, great questions. So yeah, in ambulatory care, medication reconciliation can be conducted. So at the time when the patients come to your community pharmacy, you can look at the patient profile. You can ask the patients whether they have a medication list of that they are currently on. If you have an electronic system in your pharmacy, then you need to add all these medication to his list in your community pharmacy. So anytime they come to your pharmacy and they need their medication to treat diabetes, then the list of medication is currently in your record. So by interviewing the patients, taking the up-to-date list of medications, documenting it in your system, this is a very important steps that you need to have in order to have medication reconciliations in your community pharmacy.
And there is the last question. Well, there will be standard form to be filled for medication reconciliation purpose in all healthcare facility in KSA, as this will rely better communication between transfer of care.
I don't know if there will be an initiative to unify a form, to have a unified form for such thing. But any institutions, including my institutions, we put our forms and we keep changing the form. Not keep changing the form, like we update the form from time to time according to the feedback that we receive. Some of these forms are electronic and some of these forms are manual, like what I mentioned. So it depends on your institution infrastructure whether they adapt the manual format or the electronic format. But personally, I don't think there is a need to have a unified form for such a process, as long as the medication history taking is accurate, and also the medication list that will be given to the patient at the time of discharge is accurate and thorough. That include all medication that the patient is on, with the information including dose, dosage form, frequency, and the indication that this medication is written for.
Yes. Thank you so much, Dr. Asiri. So at the end, on behalf of Saudi Patient Safety Center, we would like to thank you, Dr. Asiri, and our audience for their active participation. Thank you so much. As a part of Saudi Patient Safety Center effort to provide you with the timely topic and interesting speakers, we would appreciate if you would fill our evaluation survey. Again, thank you so much to joining our webinar today. Thank you, Dr. Asiri.
Thank you so much. Thank you so much. Have a great night.
Thank you.